So with this, I request Dr. Raju to please upload his presentation and start.
Yeah.
Thank you.
Thank you, sir. Thank you, sir, for giving me an opportunity to share the dais with you. You have been my mentor. Slides. Well, CSR and CME, these are not only the most commonly encountered in our day-to-day practice, but also confused. So there is a lot of confusion between these two entities. So let me start with spotters. Is this a CSR or a CME? This is spotter number 2. By history, how can we get some clues? A patient with a typical CSR may commonly complain of a positive scotoma and micropsia, while patients who may have CME may present slight discomfort and photophobia. So when you ask a history, it's very important to ask pointed questions. If you casually ask, do you use steroid medicines, the patient may not come out with the correct answer. So you need to ask very specific questions. Do you use any skin ointments? Do you use any inhalers? Then they come out with the correct answers. Also, when you're taking a history, assess the patient's personality and look for Cushingoid features. It's very important to know that a lot of drugs cause CSR, especially corticosteroids, and also don't forget sildenafil. The clinical findings include the neurosensory detachment, PEDs, and RPE changes in CSR, while patients with CME, we can see the intraretinal cysts in the foveal region on 90D or a 78D examination. Coming back to this spotter, is this CSR or CME? Well, when we did an indirect ophthalmoscopy, this patient had a detachment that was extending beyond the arcades. And you can see the difference between the attached and the detached retina there, and the patient had a break inferiorly. So this was a patient with a retinal detachment, a shallow retinal detachment, and we need to look for corrugated appearance in these patients. So it's important before we rush doing an OCT to do a good IDO, because differentiating an RD is more important so that we don't lose and do harm to this patient. Coming to the spotter number 2, so whenever you suspect a patient of CSR, always try to have a look at the disc. This patient had an optic disc pit, and this patient, when you do a OCT, you will see the Scheisser's cavity. This is another patient who came with sudden decrease in vision. So how do you go about managing this patient? Would you directly do a OCT, or what else would you do? So most of us would continue and do a OCT in this patient. So what would you do next? This shows a serous detachment, but also look closely, there is also a choroidal elevation. So in this patient, it's important to do a good slit lamp examination, because this patient had inflammatory cells in the vitreous cavity. And ruling out inflammatory pathology is very important in these patients. So OCT is not the next thing to do. Do a good slit lamp examination and rule out inflammation. And when we went ahead and did an angiography, this patient turned out to have multiple pinpoint leakages suggestive of a posterior scleritis. So this patient would require a steroid treatment. These patients did well with steroid treatment. This is another patient who came with a decrease in vision, and he was previously treated with a presumptive diagnosis of exudative RD by a local specialist. He was given pulse steroids and also immunosuppressives. Because the vision did not improve, he came to us, and when we did the FFA, we could see that he had multiple pooling points in both the eyes. These were actually multiple PEDs. And this has to be correlated with your OCT, and this combination use of FFA and OCT helped us to clinch the diagnosis of bullous CSCR. So all we had to do was to stop his steroids in these patients. So it's very important to look for each and everything in these patients. This is another patient, again confused as CSR. The FFA clinched the diagnosis of idiopathic CNVM in this patient. However, OCT is a very important tool when it comes to monitoring these patients. One can monitor this patient on a serial basis and see not only the reduction in the height of the SRF, but on-face OCT images will show us the reduction in the area of the CSR. Again, another important point is to get the OCT of both the eyes. This patient presented with decrease in vision in one eye, while the other eye showed the PED. This is a recent classification, again classified as the simple, complex, and atypical. This is published in Ophthalmology Retina that Sir was alluding to. They are classified as major criteria and minor criteria. I will not go into the details, but you may have to do both OCT and the choroidal thickness. So increase in choroidal thickness is one of the minor criteria that has been considered in this classification, apart from the typical ink blot appearance on FFA or the smokestack appearance on FFA that we all commonly know. In patients with chronic CSR, you may see the RPE changes and the RPE tracks, and autofluorescence is another tool which you can use to monitor these patients. When it comes to the management, most of us know that CSR patients do well with masterly inactivity. You don't have to do anything, just reassure the patient, look for the risk factors, ask them to avoid smoking if they are smokers, and rule out any drugs that if they are taking. So if the patient is asymptomatic, like if you observe these patients for 4 to 5 months, and if the patient responds, you don't have to do anything. However, if they have recurrent episodes after FFA, if the leak is extrafoveal, we have to just do a focal laser. Most of these patients will do well. If the leak is subfoveal, then with the availability of the subthreshold laser, we may have to consider that. PDT right now is not available, but PDT used to work very well when we were using it before. So this is a patient with extrafoveal leak who did very well post-laser. Coming to the medical management, eplerenone is safe, but it is not superior to placebo in chronic CSR. We need to watch out for hyperkalemia in these patients. Antioxidants, again, do not show any benefits with respect to visual acuity, but they are known to reduce the fluid significantly. The role of NSAIDs in CSR is very less. However, their role in cystoid macular edema is very important, because we see a lot of patients which is related to, CME is related to the inflammatory pathology. So in these patients who present with decrease in vision would be classified as clinical CME, while those patients who are asymptomatic would be considered as angiographic CME. Depending on the duration, the patients who have CME persisting for more than 6 months would be considered as chronic CME. However, a working classification would be post-surgical CME and non-surgical CME. The diagnosis of CME is very easy. We have a typical history and biomicroscopic findings. When you have to manage this patient, we have to answer this question, why this patient has developed a CME. So it could be operation-related causes, or it could be patient-related factors. One has to look for the surgical events like a PCR or a vitreous loss in these patients, and also a retained cortex. And when it comes to patient factors, compliance, most of these patients, we would have given them drops in the postoperative period, but they might not be compliant to the treatment that is there. And we also have to rule out the comorbid conditions. However, it is important to remember that CME can happen after a perfectly done surgery. So in these patients, look carefully for the inflammation that is there, and we need to titrate our treatment based on the inflammation. Now, would you treat these patients based only on clinical findings, or would you want to go ahead and do an OCT? I would suggest always go ahead and do an OCT, because vitreomacular interface abnormalities will be there. This patient, as you can see here, has got a point traction, and if you don't do an OCT in these patients, we are going to miss them. And these patients have to be dealt with surgically. Again, we need to differentiate between diabetic macular edema and pseudophakic macular edema. And when it comes to the management of pseudophakic CME, there are 2 points when it comes to the management. One is the prevention part, that is the prophylaxis. Second is the treatment. So when it comes to prevention, you have to start the treatment before you operate these patients. So it's better to start them beforehand, at least by 1 week before or 3 days before, with NSAIDs. And NSAIDs with steroids are said to be better than giving only steroids. This is for the prevention part of it. So to prevent post-surgical CME, use of NSAIDs is recommended, with or without steroids. Now, which NSAID is to use? The ketorolac is supposed to be better as per the evidence because it has got better antechamber and vitreous penetration. However, these two drugs have got better market penetration. As far as managing pseudophakic CME is concerned, there is no standardized treatment. So most of us would follow this step-ladder pattern, start with topical steroids and NSAIDs. Important point is to add an ointment at night time. This is what helps in these patients. And go in a step-ladder pattern. If it doesn't work, then one can consider posterior subtenous injection. And finally, oral steroids. Intravitreal injections or implants can be considered at a later point of time. As far as what you should do, it's better to start both NSAIDs and steroids as a combination as far as the treatment is concerned. Role of anti-VEGF in CME is actually very limited. It should be only reserved for eyes which are unresponsive to conventional treatment and can be considered in patients with infectious etiology where immunosuppressive treatment could be detrimental. As far as CME in retinitis pigmentosa is concerned, oral azathosamide has the strongest clinical basis and should be the first line of treatment. Dexamethasone implant is showing promising results as per these two recent studies. The take-home message here would be to stratify the patients based on the risks, and we have to tailor-made the management for our patients based on the risks. So one may need to start steroids preoperatively and taper them very slowly if the patient is a uveitic patient with the cataract, and one may need to stop prostaglandin analogs in patients who are having glaucoma. So this is the step ladder pattern that I would like to use in my patients. Thank you very much.
We have our Dr. Nitin Verma here, our guest speaker. Should I please give some comments on any questions from your side to Dr. S. Raju about CME and CSR?
I think the important thing with CME is to have a very high index of suspicion. I think the use of OCT has revolutionized that. I think it's mandatory to also rule out pre-existing macular disorders even before one does cataract surgery. And certainly any reduction in vision or unusual visual symptoms, I think an OCT is important. I think that's really going to be the answer. The treatment is fairly standard, and there is a definite step-ladder pattern that has been suggested, which works very well.
Raju, will you prefer a DEX implant in CME, or you will give a posterior subtenons?
I prefer to give a posterior subtenons.
I think this message should be very clear. If it is a non-resolving cystoid macular edema, then posterior subtenons is the treatment of choice, and it works beautifully. There is a situation like in diabetic patient, we know the incidence of CME is high. So in that also your choice is posterior subtenon, or you combine with the anti-VEGF?
So if there is a component of diabetic macular edema that is there, when we see if the patient has diabetic retinopathy, then I would consider anti-VEGF in these patients.
Coming to CSR, I think CSR is one of the most common encountered macular disease in our practices. And till when do you go for a conservative management, and when do you advise any treatment in cases of central serous retinopathy?
So I would usually wait for up till 3 to 4 months is my waiting time, and most of these patients would settle down by that time, most of my patients. And if they don't settle down, then I would do an angiography at the end of 3 months.
Do you think there is any role of epilunon or epitus? Is there any data available for you or in your patients where you feel epitus or epilunon is helpful?
So in case of acute CSR, I would not use any medical management to begin with. So I usually reserve it for chronic CSR or those patients who are not responded to the treatment or observation for the first 3 months.
Dr. Malika, any comments from your side about eplerenone?
Yeah, certainly eplerenone can work in some cases. So CSR is such a heterogeneous disease that in some patients we find recurrences happening, in some we don't, and then we find some cases responding to focal laser and some don't. Then some most respond to PDT, but some don't. And when they don't respond to PDT, sometimes you find they respond to anti-VEGF, and the others they respond to eplerenone. So we try all these treatments, and now PDT not being available, more dependent on eplerenone and anti-VEGF as well, apart from focal laser. So yes, some cases do respond to eplerenone where they did not respond to anything else, yes, but some don't.
Submacular leaks is one of the gray areas. Previously we had photodynamic therapy, but now we don't have PDT available in our country. So these are patients with pachychoroid disease, and you can use drugs which can penetrate into the choroid. I think alfrepicept and Pagenex or brolucizumab is one molecule which I think will work in these conditions of pachychoroid or submacular subfoveal leak. Any comments, Raju, from your side? Any experience?
I have not used anti-VEGF in this set of patients, but probably, as you say, that it may have a role, especially when they have the...
Yeah, I have a lot of experience with anti-VEGF in CSR and excellent results, especially when nothing else works. Even I have cases where PDT has not worked and you get excellent results with anti-VEGF.
See, there is a two subsets of patient. One is a normal CSR and other thing is pachychoroid disease. So if the CSR is not resolving, then always go for an enhanced depth imaging. What Raju showed in his OCT, there is a thing what we call as an enhanced depth imaging, where you measure the thickness of the choroid. For the general ophthalmologist, what is the thickness of choroid? It comes around 287 to 300. So anything above that, above the age of 50, that means it's a pachychoroid disease. So in pachychoroid disease, anti-VEGF is likely to work. We have seen reports where CSR getting resolved with anti-VEGF. So patients of CSR who are not resolving on conventional therapy, you can always do an EDI, label them as in pachychoroid central serous retinopathy, and then you can try. I have been trying brolucizumab. I'm finding good results with brolucizumab in these kind of patients. With this, any comments from Dr. Malika?
There was the CONTAIN study which compared aflibercept with the observation for chronic CSR, monthly injections with sham versus aflibercept. And 50% of the eyes with aflibercept were completely dry, which they were not resolving earlier. So it helps. And it's because it's a hyperpermeability reduction, choroidal thickness reduction happens. So that's how it works.
So the message is not all CSR?
Yeah.
CSR with pachychoroid. CSR, I repeat again, CSR with pachychoroid. So it's before injecting, do the choroidal thickness mapping. And if you are able to label these patients as pachychoroid, then only the